Hi, everybody. Thank you so much for coming. I see a lot of you popping in. Hello, thank you so much for taking the time out of your evening to be here with us. We're really excited to get this program started. I'll give it about another 10 seconds to let people start popping in, and then we will get started. All right. Well, good evening, everybody, and welcome to Destigmatizing Schizophrenia, a comprehensive overview of its diagnosis and management, brought to you by NAMI Cook County North Suburban, Dr. Matt Filippo, a psychiatrist at Advocate Lutheran General, Dr. John Rooney, a second-year psychiatrist resident at Advocate Lutheran General, and the Glenview Public Library. I would like to take a second to thank the Glenview Public Library for sponsoring this event. The Glenview Public Library offers a variety of programs, collections, and online resources for all ages and interests. The Glenview Public Library is located at 1930 Glenview Road for those interested in stopping by. Thank you so much for your support for making this event happen tonight. I am Bree Hoekstra, the Program Director at NAMI Cook County North Suburban. NAMI, or the National Alliance on Mental Illness, is the nation's largest grassroots mental health organization, providing public awareness, no-cost support, and education programs online and in person so that people and families affected by mental health conditions can build better lives. We are a lifeline to individuals and families who do not know what to expect in their difficult life journey. We offer classes, support groups, and do a lot of local advocacies for mental health. Our programs are completely free and open to those in our community service areas, but we do not turn anyone away who is in need. We are so pleased to have you all here tonight at our fourth webinar in our Mental Health Conditions, What You Need to Know series. This year, each month, mental health professionals will dig deep into a variety of mental health conditions to provide further education to raise awareness and fight to end the stigma surrounding mental health. For our topic tonight, Dr. Matt Filippo and Dr. John Rooney will further educate us on schizophrenia, specifically related to understanding schizophrenia, such as the definition, symptoms, and impact of this mental health condition, causes and risk factors, including theories and the role of early detection and intervention, current treatment options, and tips to manage. NAMI National states that schizophrenia is a serious mental illness that interferes with the person's ability to think clearly, manage emotions, make decisions, and relate to others. It is a complex, long-term medical illness. NAMI National also states that the exact prevalence of schizophrenia is difficult to measure, but estimates range from 0.25% to 0.64% of US adults. This webinar will help anyone who is interested in developing a deeper understanding of schizophrenia, how to start recognizing symptoms in themselves or someone else, and the impact of societal perception and stigma surrounding this mental health condition. We will leave plenty of time for Q&A at the end, but if you would like to type your questions in the chat box during our conversation, please do. We have two guest speakers with us tonight, Dr. Matt Filippo and Dr. John Rooney. Dr. Matt Filippo is a licensed psychiatrist who obtained his bachelor's degree in neuroscience from Claremont McKenna College and his DO degree from Western University of Health Sciences. Dr. Filippo went through his residency program and his chief residency program at Advocate Lutheran General Hospital. Currently, Dr. Filippo spends approximately 80% of his time as an outpatient psychiatrist and 20% of his time as an inpatient psychiatrist. Dr. Filippo also runs the Advocate Lutheran General Hospital's ketamine program, as well as teaches the introduction and advanced psychopharmacology classes. Our second guest speaker tonight, Dr. Rooney, obtained his bachelor's degree in 2018 in molecular and cellular biology from the University of Illinois at Urbana-Champaign. He later attended the Chicago College of Osteopathic Medicine, graduating in 2022. Dr. Rooney is currently in his second year psychiatry residency program at Advocate Lutheran General Hospital. Both individuals have much experience and knowledge to share with us this evening. And we are so thrilled to have them both here tonight to further educate us on this ever important topic. So I am honored to welcome our guest speakers tonight, Dr. Matt Filippo and Dr. John Rooney. Dr. Filippo, I think you may be on mute.
Oh, perfect. Should we get started?
Yes, absolutely.
Oh, awesome. Oh, thank you, Brianna, for that wonderful introduction, and welcome everybody. Today we'll be talking about destigmatizing schizophrenia, shedding light on a condition that too often is hidden from society. Today, we hope to demystify its symptoms, dispel misconceptions, and illuminate treatment options, especially the importance of early diagnosis and treatment. Brianna gave an excellent introduction, so I'll be able to skip over most of the slide. But to be brief, I wanted to introduce myself, as well as one of our rising psychiatry residents, Dr. John Rooney. We are both based at a Lutheran General Hospital in Park Ridge, both locals from the area, and we are privileged to both see patients on the inpatient and the outpatient side, really seeing how schizophrenia manifests in different phases of life and with different acuity levels. Apologies for all the text on the screen, but I really like to spell out a table of contents for our talk today, just so everybody kind of has a reference to refer to. I'll speak more in depth on this and the objectives for today on our next slide. Some objectives for today. We'll first focus on introducing schizophrenia as a concept, giving some historical perspectives, context, and exploring the functional impact this has on one's life. We'll then delve into some of the pathophysiology, the genetic, epigenetic, and environmental risk factors, review some of the epidemiology and standard course of the illness, both the natural course of untreated and the course that can be modified when treated. Then we'll review various treatment options, including medication and non-medication options. We'll finally wrap up discussing what I think is the most important study in the treatment of schizophrenia and highlighting the importance of early identification and early and comprehensive treatment. Finally, we'll end with concluding remarks and a question and answer session. To lead off, while often hidden from society, schizophrenia is a relatively common illness. Very different prevalence rates have come out in different countries from different survey data, but approximately 1% of Americans will be diagnosed with schizophrenia sometime in their life. To put that number in perspective, this is slightly more common and much less discussed than more commonly discussed illnesses such as celiac disease, seizure disorder, and even type 1 diabetes. While schizophrenia has been written about since almost the time we invented the alphabet, detailed case reports of this haven't really existed until the 1800s, and we're still discovering the neurobiological underpinnings of schizophrenia today. We're lucky to live in a time where there are many available treatments out there. That said, there are many people alive today, potentially some in this room, that lived in a time where there was no medication treatment for schizophrenia. We know that early and comprehensive treatment is critical in preventing progression of the disease, and that public perception of schizophrenia is often distorted from what we see in reality. As far as defining schizophrenia goes, schizophrenia is a term that stems from Greek etymology, and excuse my pronunciation, as I assume this is not correctly pronunciated, but using the term schizene, meaning to split in Greek, and phren, meaning the mind, literally means a splitting of the mind. While psychiatry's definition of schizophrenia has changed over the years, it's converged on the current definition of requiring 2 or more of delusions, hallucinations, disorganized speech and or behavior, and negative symptoms. These include being unable to express emotions, having very little speech production, lack of interest and motivation to engage in activities. And then I'll also point out that there are many cognitive symptoms seen in schizophrenia that often get lumped into the negative symptoms. I personally think the cognitive symptoms of schizophrenia are thought better separately from the negative symptoms, but that's a small aspect that won't come into play today. To that point, to be diagnosed with schizophrenia, there has to be 1 month of active symptoms, though there has to be at least 6 months of significant functional disturbance from symptoms. has to lead to some sort of functional impairment. In addition, so again, dictionary definition, we're able to kind of know what we're talking about when we're talking to somebody else. These symptoms cannot be due to a substance, they cannot be due to another medical condition, and they cannot be due to another mood disorder. If somebody comes in, they're using a drug, they're becoming psychotic, that's not schizophrenia. That's a substance-induced psychotic disorder. If somebody's coming in, they've got a autoimmune encephalitis, inflammation in the brain, that's not schizophrenia, that's the autoimmune encephalitis. If somebody's coming in manic or somebody's coming in depressed and there are some psychotic features with that, that's not schizophrenia, that's bipolar disorder with psychotic features or depression with psychotic features. Some historical perspectives on schizophrenia are presented below. Prior to the 1800s, descriptions of what today we'd call schizophrenia were very, very limited. Theoretically, there have been some, the first case report or description of possible schizophrenia started shortly after the alphabet was invented in Egypt. But as far as codified case reports, it really wasn't until 1797 where the first detailed case report came out. And it wasn't until almost 100 years later that the concept of schizophrenia was organized as the term first called dementia praecox. From a Latin etymology standpoint, dementia praecox means premature dementia. This approximates what we understand schizophrenia to be today, though there were some subtle differences back then. Shortly thereafter, the term dementia praecox was kind of changed, and schizophrenia, the term, what we would call it today, was changed to something called hebephrenia. Hebe being the etymology for puberty, phrenia, again, kind of being the mind. Noticing even in the 1890s that this tended to happen right after puberty or shortly after puberty, having that linkage in their mind. This was very important historically as it differentiated what we now call schizophrenia from what was then called also manic depression, or what we now call bipolar. Point being, all psychosis is not one thing. There can be psychosis and manic behavior that's associated with bipolar. There can be psychosis and other behavior associated with schizophrenia. And then, as mentioned earlier, there can be psychosis from many other things out there as well. With that, it wasn't until 1908 where this was finally codified as the idea of schizophrenia. A splitting of the mind, we're integrating difficulties in personality, difficulties integrating thinking, and difficulties integrating memory and perception. Adding more historical context to this, the early definitions of the disorder were focused on ideas of the mind. You can think of the mind as a black box or a complex piece of equipment with contents that are mysterious to us. It really wasn't until we had a lot of the technology we've had in the last century where you really could look in the brain, see what's happening, have this objective piece of equipment that wasn't just this mysterious black box, but which you actually could see and put somebody in a functional MRI machine and see what areas of the brain are active and taking up glucose and sugar. This did not exist in the past when the idea of schizophrenia was first existed, and I think gives credence, or is one of the reasons some of the older definitions were as they were. Prior to the 1950s, treatment of schizophrenia was very, very limited. We did not have any effective medication treatments out there. Treatment consisted of things like psychoanalysis, archetypes, something called the overbearing schizophrenogenic mother, which is not exactly anything used or talked about today, and very, very invasive and controversial treatments, including the precursors to electroconvulsive therapy, insulin convulsive therapy, hydrotherapy, psychosurgery, these other very controversial precursors to what we call ECT today. It wasn't until 1950 when the first antipsychotic, Thorazine, was developed to treat what was then called shock after surgery. For those who maybe have had surgeries before, had family members or others, it's not uncommon. One can, after surgery, wake up confused, disoriented, sometimes agitated. What today we might call delirium or metabolic encephalopathy, then was kind of called surgical shock. The goal back then was to develop a better antihistamine, think medications like Benadryl, things that can be sedating, to kind of treat the shock after surgery. To that point, one of the first case reports for cognitive behavioral therapy, again, the first non-medication treatment option out there, that's a therapy that's somewhat helpful for schizophrenia, didn't occur until 2 years later in 1952 when Aaron Beck invented CBT. Actually was used for a case of schizophrenia back in 1952. Here's a graphic illustrating the discovery and the refinement of antipsychotic medications over the years. And while currently available agents have come out since the year 2000, These all at present, the newer ones at least at present that have come out since this graphic ended, are all refinements of the older tools on this graph. These have all kind of been through the same background refinements. Some of the newer ones have had less side effect profiles, but there's not really been a major change in the treatment options since the year 2000. And now I'll hand this over to Dr. Rooney to go through a little bit of the pathophysiology of schizophrenia.
Thanks, Dr. Filippo. Good evening, everyone. Thanks for having us. I'd like to take a few minutes just to discuss some of the theories surrounding the pathophysiology of schizophrenia. I think not only do they provide a useful framework to try to understand some of the specific problems in living that patients with schizophrenia experience, but also provide us a framework to begin to look at interventions and treatment. And no discussion of the pathophysiology of schizophrenia would be complete without discussion of what's known as the salience hypothesis. So this is one of the earlier theories of the etiology of schizophrenia, rooted heavily in the concept of the mind that comes to us from the school of cognitive psychology. It's basically based in the premise that one's experience of the world is not a completely accurate reflection of true or objective reality. One's experience of the world is a product of the brain's perception of reality, which is influenced by our past experiences, our knowledge of the world, our belief systems, as well as direct sensory input. For example, yesterday I took my dog for a walk around our neighborhood. What I experienced on that walk was not the physical neighborhood itself. It was my brain's perception of the neighborhood that was produced by billions of neurons communicating with one another in my brain. And this was all influenced by the past experiences I've had in my neighborhood, my knowledge about where things are in the neighborhood, as well as what I directly see and hear. And just in that simple example, one can imagine this is an enormous amount of information that we're being bombarded with in daily life. And we wouldn't be able to make sense of things or navigate the world if we were consciously aware of all of these different factors that go into our perception of the world. So the brain takes some shortcuts, so to speak, to consolidate this information that we can practically manipulate to use as a context to experience this world. And part of that is mediated by a mechanism called basically saliency, meaning the brain has an automatic mechanism that can detect the most important information in our environment, not only based on what we hear and see, but also based on our past experiences. That's a simplified version of this objective reality, but provides a usable context to understand what's going on around us. But what's important to recognize is that this consolidated perception of the world is not a one-to-one representation of reality. It's the mind's consolidated view of what's truly going on in the world. And the automatic ability of the mind to detect what's important in understanding what's going on around us plays a very important part in that. And the crux of the salience hypothesis as it relates to schizophrenia is what would happen if there's some sort of breakdown in that mechanism to pick out the most important things going on in our environment as we understand the world around us. And I think the best way to illustrate that is through a brief thought experiment. Dr. Filippo, if you could advance the next slide there. Thank you. So I'd like you all to just take a look at this picture here and just in a few seconds, try to answer the question to yourself, what's going on here? So looking at this picture, a lot of you are probably thinking, well, this looks like a busy highway. Some of you may recognize this as the inbound Kennedy Expressway. And it seems pretty simple. We understand that this is a highway, but when you think about it, there's actually a lot of cognitive processing that goes into understanding what's actually occurring here. So how did we come to the conclusion that this is a busy highway? Really, there's only a few critical pieces of information that we use to generate that understanding. We see a large road, we see a lot of cars, a motorcycle, and a big city in the background. This looks like a busy highway, but there's a whole lot of other information going on here. And the it's just as important to recognize the important aspects of the picture as ignoring the less important aspects. For example, you might see a particular car that reminds you of a car your parents had in the past. You might see the patch of grass on the left-hand side of the screen that looks like it might need some water, but we don't pay attention to that in generating an understanding of what's going on here. There's this innate mechanism of identifying what's the most important aspects going on around us to understand what situation we find ourselves in. So I'd like to pose a hypothetical question. Let's say there was one aspect of the scene here that I told you was the most important thing going on. Next slide, please. So let's pretend for a moment the most important thing in this scene is this black car here. There's something critically important about this car. So now, giving you that information, what sort of explanation would you generate for the question, what's going on here? You might think there's something very valuable in this car. You might think possibly there's something sinister about this car. Maybe the driver of the car is fleeing from something. So based on where our mind focuses attention, places importance in our environment, it drastically changes our perception of what's going on, our perception of reality. And that's truly the salience hypothesis of schizophrenia, and that either the disease itself is produced by or causes a dysfunction in this innate mechanism of the mind to attribute importance to information in the environment. And as a corollary to that, when there's dysfunction in this process and we begin to place importance or salience into aspects of the environment that perhaps aren't necessarily important to understanding the situation around us, our appraisal of the scene, our understanding of the world becomes more heavily influenced by our beliefs, our past experiences, and our emotions. Next slide, please. I think a real world example that really demonstrates this change in perception that occurs when we begin to have a breakdown in our ability to attribute significance to things in our environment is best demonstrated by the life of an English painter named Louis Wain. So Louis Wain was a painter who became famous for his paintings of cats throughout his career. And it's believed that Louis Wain suffered from schizophrenia. And, we know through accounts from his life that as he aged, his disease progressed. And this was concomitant with a stylistic change in the manner in which he portrayed cats. So this is an example of one of his earlier works. Looking at this picture, it very much resembles what most people would think of as a cat. Easily identifiable. This is the perception of reality that most other people would share when contemplating what is a cat. What does it mean? What does it look like? What does it really mean in terms of what we're experiencing? However, as time goes on, we see a pretty significant change in Louis Wain's perspective of what a cat is, what aspects of its presentation are important, and how that alters, the ultimate projection of what this animal means. Next slide, please. Thank you. So this is one of his later works, still earlier in his career. We can see the cats are taking on a more anthropomorphic, almost cartoon-esque kind of presentation. And next slide, please. As time goes on, we see that the cats are beginning to take more of a peculiar image, more kind of emotive, arguably, possibly even a little bit sinister. And as time goes on, Wayne's projection of cats begins to become starkly different. Next slide, please. As demonstrated here. Next slide. And finally here. Oh, sorry, next slide, please. And so now, next slide. Thank you. So, when looking at, Wayne's depiction of cats based on the beginning of his career versus the end of his career, we can see that we can infer at least that Wayne's perception of cats as time moves on is basically placing importance on different aspects of cats that's being heavily influenced by his own thoughts, feelings about the animal, and thus his understanding of the cats, and to take a step further, perhaps understanding of the world, becomes much more heavily colored by his beliefs and internal experience, such that his depiction of cats near the end of his career it becomes very, very different than what most other people would probably imagine cats to be. So it's easy to understand how when there's this change in perception of the environment and understanding of reality, it becomes very difficult to navigate the world, the reality that most other people share. And it's easy to see how this could be the basis of things like delusions, as well as the cognitive dysfunction that goes along with schizophrenia. Next slide, please. Thanks. So that was a little bit abstract. And as Dr. Filippo said, we're now living in the age of advanced science, having medical equipment that can identify changes in biology, changes in the brain itself, which of course is the substrate of the mind. And I think as a corollary to that is truly the organ affected by schizophrenia. So let's take a look at specifically what we think is changing in the brain during the course of schizophrenia. One of the more popular and earlier theories about the actual biological mechanism of schizophrenia was called the dopamine hypothesis. And this hypothesis was generated based on some findings that were seen in the early days of study of the illness. First, medications like cocaine and amphetamines that stimulate the release of dopamine can produce the positive symptoms of schizophrenia, things like hallucinations, things like delusions. And at the same time, withdrawal from those same medications actually can produce a symptomology that's consistent with the negative symptoms of schizophrenia: inability to concentrate, lack of motivation. And finally, it was found when the first neuroleptics, thorazine, were developed, which we know block the transmission of dopamine. This tends to actually improve the positive symptoms of schizophrenia, although it doesn't tend to have quite as much of an effect on those negative symptoms, and in some cases can make those a little bit worse. So based on these findings, we came up with what's known as the dopamine hypothesis. And in the next slide here, I have a graphic depiction. So first, I'd like to direct your attention to the blue circle at the bottom of the screen. So this is meant to represent the ventral tegmental area, which is a dopamine nuclei in the midbrain at the top of the brainstem. And this is the source of the dopamine in question here. So the dopamine coming from the ventral tegmental area is going to two structures of importance here. The first being the prefrontal cortex. The neurons are projecting through what's called the mesocortical tract in that context, as well as the limbic system, to which the neurons within the ventral tegmental area are projecting through what's known as the mesolimbic tract. So when dopamine is released in either of these tracts, they stimulate what's called the D2 receptor in neurons in these brain structures. And dopamine through the D2 receptor has a stimulating or excitatory effect in both areas. So what happens when these areas are stimulated? Well, it's important to understand exactly what these structures do at baseline. Next slide, please. Thank you. So the prefrontal cortex is responsible for higher level cognitive functioning. It can be thought as sort of the supercomputer part of the brain. This is the region of the brain that's responsible for things like critical thinking, impulse control, the reason why we don't run red lights, we slow down at yellow lights, as well as higher level abstract thinking. And when dopamine is released through and stimulates the D2 receptors in neurons within this area, it tends to have a supportive nature to these processes. But what happens when the limbic system is stimulated? What does this region do? Next slide, please. So for lack of a better word, the limbic system can be thought in brief as basically a salience detector. This is the part of the brain that when stimulated tells us that something is important in our environment. For example, if we're walking in the woods, we see a bear, the limbic system becomes activated. And this is responsible for not only identifying, okay, the bear is something I want to pay attention to. Sure, there might be grass, there might be a river here, but the bear here is really what I'm focused in on. In turn, the limbic system will communicate to other areas of the brain, like the hypothalamus that regulates the autonomic nervous system, creating this fight or flight response. Next slide, please. So the dopamine hypothesis, in short, is basically schizophrenia is caused or produces a relative shunting of dopamine away from the mesocortical tract to the mesolimbic tract. And in doing so, there becomes a deficiency of dopamine transmission within the prefrontal cortex. So the kind of higher level cognitive processes like attention, motivation, abstract thinking become impaired. Whereas when this dopamine is shunted over to the limbic system, this creates a general defect in salience. The mind begins to attribute meaning and significance to things in our life that most other people wouldn't attribute significance to, which underlies things like delusions. Additionally, stimulation of this region of the brain is thought to underline things like hallucinations as well as impulsivity and at times agitation in the course of schizophrenia. Next slide, please. Thank you. And next slide. So we were all satisfied with the dopamine hypothesis for many years until there were some findings that kind of put a wrench in this as being a completely comprehensive mechanistic understanding of the disease. So medications that block the NMDA glutamate receptor, things like phencyclidine or PCP, can produce a clinical syndrome that's more or less indistinguishable from schizophrenia, that temporarily causes things like positive symptoms like hallucinations and delusions, while at the same time produces negative symptoms, deficits in cognition and changes in speech. Additionally, there are rare autoimmune conditions that can interfere with glutamate transmission that also produce symptomology. And just kind of logically, you might think as we're going through the dopamine hypothesis, you know, if this was the end all be all of what causes schizophrenia, what causes dopamine to suddenly shift from the mesocortical tract to the mesolimbic tract? It's dopamine isn't salient. It doesn't know where it's supposed to go. There has to be some other mechanism driving this process. And it's thought that global reduced functioning of the NMDA glutamate receptor may partially explain this. Next slide, please. Thank you. So I'm going to introduce another component of this circuit here called the cortical pyramidal neuron. So these neurons release an excitatory neurotransmitter called glutamate. and when mediated through the NMDA receptor, has a stimulatory effect. So if in the context of the glutamate hypothesis, if we were to suppose that the NMDA receptor becomes hypofunctional or has some sort of impairment in function, then the relative stimulatory effect of glutamate transmission in this area would cause a relative deficiency of dopamine release within the mesocortical tract, which would explain the presence of negative symptoms in schizophrenia. Next slide, please. And so I'm going to introduce yet another component in this diagram, the GABA interneuron. So GABA is an inhibitory neurotransmitter within the brain. And there are what are called GABA A receptors within the neurons that compose the mesolimbic tract. And the GABA interneuron here basically serves to function as a brake. So it has an inhibitory effect on the mesolimbic tract and basically hyperpolarizes or depresses the function of these neurons to slow down the release of dopamine that actually reaches the limbic system. So now how does glutamate play into this? So there are actually NMDA receptors on these GABA interneurons. And if, again, in the context of the glutamate hypothesis here, if the NMDA receptor becomes hypofunctional, then we'll have it'll have a relative inhibitory effect on the inhibitor here. So if the GABA interneuron isn't being stimulated, it's going to release less GABA. If there's less GABA reaching the mesolimbic tract, then basically the mesolimbic tract will run unopposed, which would underline the excessive dopaminergic activity thought to mediate the positive symptoms of schizophrenia. Next slide, please. And next slide, thank you. So, in short, again, it's not complete, it's not completely infallible, but the glutamate hypothesis currently is the leading theory, hazarding a guess as to what the actual molecular and chemical basis of schizophrenia is. And still, the question remains, what causes this decreased functioning of the NMDA receptor? What risks in the lifetime can mediate this risk of developing the disease? To which I'll pass it back to Dr. Filippo here.
Oh, Ben, thank you for all that information. Well, we're still gaining understanding of the pathophysiology of schizophrenia, and I do think we have a relatively complete circuit at this point. We're also still learning about the various genetic, environmental, epigenetic risk factors. One not uncommon question I get relates to how often will someone's child have schizophrenia, they themselves have the disease, or a sibling has the disease, or a cousin has the disease. This question often comes with a lot of stigma and guilt attached, or a parent might ask if they did anything wrong to cause this in their child. Well, I can't honestly say there's absolutely no genetic risk related to schizophrenia. The vast majority of the time, this is not something explained by genetics, and I would argue it's never explained by genetics alone. There have been some studies showing low or high paternal age contribute somewhat. Some studies showing that specific rare genetic syndromes can cause this, and even our most advanced genome-wide association studies only explain 7% of the risk of schizophrenia in the population. If one parent has offspring and one parent is, or if one parent has schizophrenia and has offspring, there's only about a 15% chance that 15 that child is going to express what we call schizophrenia. If both parents have schizophrenia, it's still not the majority of the time. It's only a 40% risk. And if you know that your identical twin has schizophrenia, it's only a 60% chance that you're going to express that disease. Point being, while genetics comes into play, there's got to be a lot more going on. In addition, we've now known that certain oxidative DNA damage, mainly from environmental exposures and certain social determinants of health, pollution, yada yada, causes some increased risk from a schizophrenia expression standpoint. We also know, interestingly, from a prenatal standpoint, viral infections such as exposure to the flu while developing in the womb leads to an increased risk of later developing schizophrenia. We know that prenatal malnutrition when baby is in the womb can increase that risk. We know that being born in the late winter or the early spring contributes. It's unclear how much of that may be due to flu season, vitamin D deficiency, something else, or both. We know that suffering multiple adverse childhood experiences itself, social isolation, and interestingly, urban upbringing, we suspect due to environmental pollution, all contribute to the risk of expressing what we call schizophrenia. And then there's the age-old debate about substance use causing schizophrenia versus correlating with it. And we'll particularly talk a lot about nicotine in the coming slides. Putting this all together, we get something called the stress diathesis model. One can have that full 7% genome-wide association study risk. You can have that full 60% identical twin risk. You're still not 100% of the time going to develop what we call schizophrenia. There has to be some other thing, some other triggers, something else that kind of leads to its full-on expression. Some sort of environmental or other risk factor must come into play, often and typically in addition to the genetic and other risk factors for it to fully be expressed. Now, moving on to the epidemiology, the peak onset of schizophrenia occurs earlier in men than it does in women. Remember, back in the late 1800s, this was called hebephrenia, splitting of the mind during puberty. In women, it occurs about a decade later, between the ages of 25 to 35. Variable studies show different numbers in populations, but approximately 1% of the US population will at some point carry a diagnosis of schizophrenia during their lifetime. And similar numbers are seen in worldwide studies. It is commonly associated with other metabolic issues, including obesity and diabetes. This is regardless of medication use, which we'll talk about shortly, and can cause diabetes, and some of them can cause diabetes and blood sugar dysregulation. Even prior to these medications being on the market, these associations were out there. It's associated with certain cancers, certain soft neurological symptoms, substance use, especially nicotine. There's debate whether the nicotine is helping to self-medicate the negative symptoms of schizophrenia, but there's one study from about a decade ago that showed up to 30% of the income of schizophrenics with public aid, 30% of that money went to cigarettes. I don't know from a personal standpoint, but I know that the price of cigarette packs I see at the gas station has only gone up since then. Luckily, the prognosis of schizophrenia is not nearly as bad as the stigma presents itself. 70% of patients will improve within 3 to 4 months. From their first psychotic episode. That said, it's very, very important to treat schizophrenia early and comprehensively. Approximately a third of these patients will live through a suicide attempt, and approximately 7% of them will die by suicide. The disease on average costs 10 years of life expectancy. Much of that is related to heart health related issues and can be mitigated by closer medical follow-up. But again, this is one of the most disabling conditions, very important to get it treated early, very important to get it treated comprehensively. Now, the course of the illness is very important to highlight. While we're all individuals and respond differently, the stereotypical course of schizophrenia is that when you've had one episode, it's much more likely the next episode is going to last longer and be worse. This should be considered a relapse and remitting disease like many other chronic health conditions that do have flare-ups. With seizures, if you've had one, it's more likely you're going to have a second. If you've had one, it's more likely your second's going to be worse than the first. This kind of chronic degeneration, this chronic relapse and remitting worsening of the disease. If you stop it early, you minimize the amount of relapses and flare-ups, the course of the disease tends to be much better. Preventing recurrent episodes is key to mitigating this cognitive decline, key to mitigating that life expectancy difference. Here's just a quick little graphic looking at the core symptoms clusters of schizophrenia and how these can impact the different social and occupational functions on the individual. There are the positive symptoms, things like the delusions, hallucinations, disorganized speech, catatonia. Think of that overactive part of the brain, that excessive dopamine kind of stimulation. There are the cognitive symptoms, difficulties with attention, memory, executive function. The way I kind of like to think of it in my head is, in a sense, it's almost like ADHD in a way, an executive function disorder. There can be a lot of the same deficits. The negative symptoms, the affective flattening, the alogia, the avolition, the anhedonia, things that otherwise might look like a depressive disorder, but are not necessarily. And the mood symptoms, the dysphoria, the suicidality, the hopelessness. These all can have varied and multiple effects that affect work, interpersonal relationships, self-care, the ability to hold a job, the ability to have a family. It's very important to take all 4 of these clusters and do what one can to mitigate the damage from them, and also see how one can work with them as opposed to against them. Now, here is another graphic looking at the stereotypical course of schizophrenia over time when not treated, so the natural history of schizophrenia. Note the decline of the progression over time, how it leads to worse and worse functioning over the years. And again, we'll talk later shortly about how important it is to treat this early, treat it comprehensively, how we can stop this pattern in its tracks if we treat it early, if we treat it comprehensively. Now, reviewing the medication treatments we have out there, we first have the first generation antipsychotics. The second generation antipsychotics came after, and then the newer serotonin dopamine activity modulators came after. There are a few very interesting compounds under study that we won't focus a ton on today. That said, these first generation antipsychotics do a very good job at one thing, and that is blocking that excessive dopamine production in parts of the brain, and also blocking that same limited dopamine production in the other parts of the brain. These do a good job of blocking dopamine. They block that mesolimbic transmission very well, and they can slightly decrease that mesocortical transmission. Point being, great job at treating those positive symptoms. Theoretically, they can sometimes even worsen some of those negative symptoms. The second generation antipsychotics block this chemical dopamine less well, and they may slightly help with the negative symptoms and the cognitive symptoms of schizophrenia, but different side effect profiles than the first generation antipsychotics. Many of these in the second generation lead to the metabolic effects, the weight gain, the blood sugar dysregulation, cholesterol issues. These newer serotonin dopamine activity modulators theoretically act as kind of a thermostat for dopamine. They theoretically should be blocking it when those levels are too high in certain areas of the brain. And like a thermostat, when it's too cold, they should be increasing those dopamine levels when it's too low in certain parts of the brain. Typically, they carry less metabolic side effects than all of the second generation antipsychotics, except for one. There happens to be one in second generation antipsychotic that on average leads to a couple pounds of weight loss. That said, the serotonin dopamine activity modulators tend to be the better weight ones, apart from that one in the second generation category. Now, these can all carry significant side effects, and major studies show 80% of individuals, 80, on these medications will stop them within 18 months. There can be cognitive side effects from these, including sedation, anxiety. There can be significant metabolic side effects, including weight gain, cholesterol issues, high blood pressure, even diabetes. Some of these can cause heart issues, including low blood pressure and different heart rhythms. Many of them can cause movement issues, particularly those first generation antipsychotics. Rigidity, involuntary movements, and by blocking dopamine, the same thing that causes Parkinson's disease, you can cause symptoms that look identical to Parkinson's disease. In addition, you can get motor restlessness, and in extreme cases, something called neuroleptic malignant syndrome, life-threatening fevers, along with other physical symptoms. Not all these medications cause all these symptoms. Not all these medications cause all these side effects. It's very important to find the right one for the individual, the person in front of you. There's no one best antipsychotic. It's who's in front of you, how's their body going to respond, working with the treatment options, knowing that there's no one best fit for everybody. Point being, many medications are available with various pros and cons. They should be individualized to the person in front of you, and it's very, very important to bring up side effects with your doctor, as many of these can be worked around and even solved. Some examples, side effects can be mitigated. If a sedating medicine is taken at bedtime, there might be a net benefit compared to no medication. You can do two birds with one stone. Take something for sleep that's not addictive, not habit forming, that can help you get better, healthier sleep, and it also treats the psychosis. That can be a win. Metabolic issues can be mitigated with a primary care follow-up, making healthier food choices, getting more physical activity, and even prophylactically taking medication to head off the metabolic effects. There are studies currently going on, testing the Ozempics of the world in patients with schizophrenia to prevent the weight gain. Not for every case, but it's not uncommon. I'll add on a metabolic medication, metformin, sometimes topiramate, to kind of help mitigate some of the weight gain and the metabolic effects you can get from some of these treatments. Heart issues can be mitigated with regular medical follow-up and screenings. The movement disorders can almost always be fixed by a dose decrease of the medication early in the course of treatment. And we have some newer medications to treat some of the involuntary movements if these movements have not been caught earlier in the course of treatment. The involuntary movements can be permanent if not caught early. They are very treatable if treated, very not going to be permanent if you catch them early enough. Though we do have some treatments nowadays to actually treat them when they've been going on for years and years and they aren't permanent otherwise. Point being, there are many medication options available. They should be selected to target the most problematic symptoms in the person in front of you. They should be selected based on the context of medical history and potential side effects. You should be having a comprehensive evaluation with your physician before starting these. They should be taking a careful heart history. They should be taking a careful metabolic history, family history of all these, Parkinson's, Lewy body, other movement disorders, other neurological disorders. These very much can inform the best treatments for the individual in front of you. Side effects can often be managed through lifestyle or medical intervention. Again, it's how do you work with the treatment options out there? And oftentimes it can be a very simple switch, even something as simple as switching the timing that makes something that was intolerable very tolerable. Now, many are also interested in using more natural treatments, such as supplements. While these shouldn't replace medication treatment, in my opinion, and the evidence base for these is more variable, some of these legitimately can be helpful. This is not an exhaustive list of every supplement that's been studied for schizophrenia or psychosis, but some selected supplements are below. Interestingly, harkening back to the NMDA hypothesis, many decades ago, people were using glycine, D-serine, and sarcosine to treat specifically the negative symptoms of schizophrenia. These are supplements that work to actually enhance that NMDA transmission. And interestingly, there's even a medication on the market, or medication undergoing clinical trials that's attempting to be brought to market that works the same way. Point being, again, if you want to try glycine, you want to try D-serine, you want to try sarcosine, that's not something I'd be against by any means. That said, it should not replace the role and the importance of medication and not medication treatments. Omega-3s are interesting. There are studies showing when given early in the course of disease during that prodrome period where you've had active symptoms maybe for a month, but you haven't had the full 6 months of actual full-on disease. If you give it early in the course, it can help both the positive and the negative symptoms. When it's given after that first psychotic break, that first episode, they've been shown to help with some of the negative symptoms. And were given for chronic episodes, they very well have not been shown to be consistently effective. There are other supplements out there. There are other things with some data behind them, but these are going to be the two most evidence-based, at least from my review of the literature. Now, some non-pharmacological treatments are listed on the next few slides. Electroconvulsive therapy has a very well-deserved stigma and is practiced very differently today than it was back in the past. That said, it can be a very effective treatment for severe or treatment-resistant cases. Again, should not be used as a first-line treatment, but I do want to put that out there and help to destigmatize ECT. It can be a godsend when somebody absolutely needs it, but it has a lot of very well-deserved stigma behind it. Various psychotherapies can be beneficial as well, including staples such as cognitive behavioral therapy, cognitive remediation, patient education programs, family intervention, social skills training, meeting the patient where they are in the community with assertive community treatment. Back in the day, it was often thought individuals with schizophrenia that they can't necessarily cognitively process these deeper therapies and benefit from it. That's absolutely not true. If somebody's coming in for depression, bipolar, they're on a medication, the recommendation should typically be also engaging in therapy. The same type of thing should apply for any and all psychotic disorders. There may be some difficulties in certain areas, but these different therapies are a very important part of the treatment as well. This one thing I did want to highlight was, in my opinion, the most important study relating to schizophrenia, the RAISE trial or response after initial schizophrenia episode. This was a study conducted around the 2010s that looked at 2-year outcome data from those presenting with first episode psychosis, and it compared the usual community care versus a more comprehensive and also guided care. There was recommendations on the medications to give, for example. It wasn't just whatever the doctor in the community typically did. Approximately 400 individuals, all between the ages of 15 to 40, were studied after their first psychotic episode and followed for 2 years. They were assigned to 2 categories. One was either in the care as usual in the community group, or the second group was comprehensive program. This included that guided medication choices, individual therapy, family education and therapy, as well as supported employment and education programs. Now, outcome data showed that those in the experimental group, those who were getting, again, the medication management, guided, the individual therapy, the family education, the supported employment and education, were much more likely to attend work, attend school. They had much greater improvement in symptoms, much fewer hospitalizations, and generally a much better quality of life, as illustrated in the graphic down here. Interestingly, and in my opinion, the biggest takeaway from this study was not people getting medication management, individual therapy, family education, and supported employment and education. It's not that they did better with that, they did. To me, the most important part and takeaway from the study was how long the psychosis was untreated greatly affected outcomes. More important than whether you got comprehensive care versus typical community care was how long was the psychosis untreated. If it was less than or greater than 74 weeks, versus or less than 74 weeks versus greater than 74 weeks, you saw a stark difference in quality of life outcomes. The point being, it's very, very important to treat this early, treat it comprehensively. Now, in conclusion, schizophrenia is a very treatable disorder and a relatively common disease. As pathophysiology, while still an active area of research, I think we have a pretty consistent, a pretty comprehensive circuit and understanding out there. We know that there are many safe and effective medications available to manage the disease. And we also know that many of these medications have large side effect profile that we need to be honest and work through, work around, work with. And it's very important from all sides to be educating ourselves, to have our patients telling us what's happening, to be able to work with the treatments despite potential side effects, rather than kind of giving up on them. As our knowledge advances, more efficacious treatments with improved safety profiles are and will be coming to market. For those that remember the graphic from earlier, the 1950 to 2000, there are quite a few medications in phase 2 and phase 3 trial right now that work completely differently from anything out of the dopamine hypothesis, that hopefully should be coming to market soon, assuming that the data turns out well. There are going to be a lot of different treatment options on the horizon. That said, as we know more, we'll be able to get more efficacious and more treatments out there. It's also important to think of schizophrenia as a relapsing, remitting condition. The more flare-ups there are, the more likely and the longer the next flare-up is going to be. It's very important to treat this early, treat this comprehensively. And we know that early comprehensive intervention improves patient outcomes, quality of life, and functional status. And thank you everybody for your time. I guess we'll open the floor for the question and answer session.
Thank you so much, Dr. Filippo and Dr. Rooney. That was amazing, very, very informative, very educational. I've personally learned so much from you too. So thank you so much for sharing all your knowledge and information. And I know that some of our guests may have some questions. So let's get that conversation going. If you do have a question, there are two different features. There's a Q&A box and there is a chat box. Please type your questions in the Q&A box. That's where I will see them. We do have one comment. It says, "Hi, doctors. Thank you so much for this wonderful information. My quotation is now practical. I think my family member is psychotic, but he has no insight and won't treat. He doesn't like the side effects of medications years ago. Would you have any insight for this individual?"
Well, and I think harkening back to that salience hypothesis, it is very common that there's not insight into this disease, especially early on in the course. In a sense, this is somebody's reality that is their objective reality. That doesn't mean it's our objective reality. That doesn't mean it's an outsider's objective reality. It's their objective reality. It can take a lot of time, effort, investment, persuasion, convincing, whatever word you want to put in there to build that insight. I find them a good carrot on the stick, or a good way to kind of convince and build that insight, is focusing on something objective like functional status. It's not uncommon. I'll see somebody 18, 19, early on in college. Maybe they were diagnosed with ADHD at 16 or 17. They noticed this functional decline in school skills, grades. Turns out that as soon as they go off to college, they have their first psychotic break. Was that ADHD at 16 or 17, or was that an early schizophrenia? Was that the prodrome coming out? I think by focusing on objective measures like functional outcomes, school grades, are you able to keep and maintain a job? How are your friends? How are your relationships? That can be a nice way to kind of bridge the gap and focus, hey, this is what the issue is. You want help here. Here are the different tools we have to help you. I also think it's very, very important to acknowledge that these medications at our disposal, they're tools, but like any tool out there, they come with a lot of risks. Now, again, oftentimes it's about finding the right medication for the right individual. We can talk I could talk quite a lot about the American medical system, big pharma, et cetera. I'll try to refrain from some of that, but oftentimes it is starting with some of the older medications or some of the higher side effect medications before insurance companies willing to pay for something a little bit newer with a little bit less of a side effect burden. But I think really getting that buy-in initially, having the patient identify where they want help, where the deficiency is the first step in kind of getting that help. In addition, I will say referring to that RAISE study, referring to the importance of treating this for in the first 74 weeks of treatment, and the stark difference in functional outcome can be a huge way to convince somebody. Again, it's not uncommon, not even necessarily for this, but okay, you go to the doctor, you get an evaluation, they tell you things are good, awesome. You haven't lost anything, they tell you things are bad. You don't necessarily have to follow what they recommend, but it's very easy to, or it's relatively easy to get an evaluation. That can be the first step in getting someone the help they need, or at least involved in the system. And again, maybe somebody doesn't buy into the diagnosis of disease on their first visit. Maybe it takes 3 visits, 4 visits to build that trust, to build that insights. But that first step is the hardest one to take.
Thank you so much for that. I especially love how you pose the question, what areas do you want help with versus, kind of telling them these are the areas that we see that you may need some support. So I really appreciated that. Thank you. Another question says, is depression with psychosis called schizoaffective disorder?
And Dr. Rooney, if you want to answer that one.
Sure thing. It's I think I'll preface all this by saying, at this point, kind of the way that we diagnose psychiatric conditions is based on a suite of diagnostic criteria and what's called the DSM, or the Diagnostic and Statistical Manual of Mental Disorders. And all of these diagnoses are descriptive. Basically the diagnosis is made based on specific symptoms over specific time course that are present in a patient, but they don't necessarily directly address the question of etiology, or what causes the disease. So basically, as a result, we have a lot of diagnoses that are related, and as our understanding of the neuropathology of a lot of these conditions expands, we've come to understand that a lot of these conditions have very similar genetic underpinnings. But in short, basically there's 4 kind of disorders in question. First being what's called psychotic depression, or major depressive disorder with psychotic features, schizophrenia, schizoaffective disorder, either bipolar or depressive type, and as well as bipolar disorder, which also can present with depressive episodes and psychotic features. And kind of the key point there is in a patient that has major depressive disorder with psychotic features, the presence of psychosis, be it hallucinations, delusions, occurs only in the context of a depressive episode. In schizoaffective disorder, the diagnostic criteria is that someone experiences psychotic episodes, they experience depressive episodes, and they can experience psychotic symptoms in the context of the depressive episode, but they also experience psychotic symptoms independent of any mood disturbance. So it's considered to be a primary psychotic disorder. And then in bipolar disorder, again, patients can experience manic episodes or depressive episodes, and they can experience psychotic features in either one of those mood disturbances. But again, the actual presence of psychotic symptoms is restricted only to the mood disturbance. If there's no mood disturbance, there's no psychotic symptoms. And it's important to make these designations, because in clinical studies, a lot of times for things like inclusion criteria, researchers will study a sample of patients that meet a specific diagnostic criteria, and that's how we know certain medications, certain therapies are effective for certain conditions. However, when it comes to just the umbrella term of psychotic illness, currently all of the neuroimaging studies, studies that assess what specific alleles of genes portend risk for these conditions, they're is a such a high degree of overlap, I would argue, in many cases, these conditions are all different symptomatic manifestations of the same pathology. But we do have actual empirical data supporting different medication options for the treatment of the different disorders.
Thank you, Dr. Rooney. Next question says, what do you think of the keto diet for this?
No, very good question. I'll say the following is a lot of speculation. My understanding, I'm very surprised this has not been done in a larger scale in humans, but there have been mouse models looking at the second generation, or especially some of the earlier second generation antipsychotics, and what the mechanism is from a weight gain, a metabolic, a blood sugar dysregulation standpoint. And interestingly, in mice, again, I'm not aware of anything large scale in humans, a lot of it comes down to an issue of your body's prioritizing burning fat, which on the surface sounds great. Oh, I'm going to make my body burn more fat. The problem is that blood sugar stays in the blood. It causes symptoms of hyperglycemia, which is what we call diabetes. The point being, there's a lot of damage from that sugar, and eventually it's going to get stored in the cells as fat. You're not actually losing any extra fat. You're just causing the hyperglycemic damage. Point being, I am a large fan of high protein diets, low carbohydrate diets. If you're going to have carbohydrates, make sure from a glycemic index standpoint, you're doing well. Simple carbohydrates, not great. Fiber, more complex ones, awesome. I don't know enough specifically on keto to say it helps from a schizophrenia standpoint, but I can definitely tell you there's plenty of mouse data showing that the keto diet helps from a minimizing weight gain and metabolic effects from some schizophrenia medications out there.
Thank you, Dr. Filippo. Next question, and I may butcher some of this language, so I apologize, but it says, can you please talk a little more about the clozapine and side effects? Does the side effects include low platelet count?
Dr. Rooney, do you feel comfortable answering that one?
Certainly. So clozapine is a very important medication. And when looking at neuroleptics in general, be it the first or second generation neuroleptics or that kind of third class, the serotonin dopamine activity modulators, there have been a lot of head-to-head trials assessing the efficacy of these medications. And time again, it appears as though clozapine appears to be superior to all of the other medications on the market in management, not only of the positive symptoms of schizophrenia, the hallucinations, delusions, but seems to be more effective in managing the negative symptoms as well, the cognitive dysfunction, the lack of motivation, deficits in executive function. That's so, one could reasonably ask, well, if this medication's better, why isn't this, the first line medication? Why don't we just jump to this medication for everyone? And it does have a very significant side effect profile. And that said, it's a lot of people, are on clozapine for many years and tolerate it just fine. It's just important to be aware of these side effects. And the biggest side effects to be aware of are what's called agranulocytosis. So clozapine itself can cause reductions in specific blood cells, specifically neutrophils, which is important to monitor because that can leave someone predisposed to develop infections. Now so because of this risk of agranulocytosis, when clozapine is started, we have to get regular blood count monitoring when it's started. So for every week, for the first 6 weeks of treatment, we have to monitor this weekly. Then it's dropped to 2 weeks. Then it's dropped to monthly, and it's just something that we have to keep an eye on. And truly what we're looking at is the neutrophil count to make sure that the cell count isn't dropping. But we do know that clozapine, as well as other neuroleptic medications, can have a myelosuppressive effect, meaning that they can cause reductions in all blood cell counts. So, low platelet count or thrombocytopenia can be caused by clozapine. But it's just something that we have to monitor for, and certainly we can intervene if needed. The other biggest side effects of clozapine are weight gain, increased risk for things like diabetes, hyperlipidemia, as well as constipation can be a very significant side effect. Other things we look out for, or it does lower the seizure threshold. So in patients that are predisposed to seizures, that's something that we have to monitor. That can be managed by using medications to prevent seizures. Additionally, it can cause what's called myocarditis, or basically inflammation of the heart, that usually will present with fatigue, chest pain, tiredness. But again, we monitor this with things like electrocardiograms to make sure there isn't any evidence of that side effect. And finally, the only other side effect worth mentioning is it well, I take that back too. It can cause what's called sialuria, or excessive saliva production. And it also is a relatively sedating medication. So we usually try to favor dosage at bedtime to facilitate sleep and minimize the amount of fatigue during the day. But it certainly can cause fatigue when it's taken. I on a positive note, out of all of the other neuroleptics, clozapine has the highest what's called 5-HT2 to D2 ratio. So it definitely has a relatively lower antagonist effect on the D2 receptor. So these motor symptoms, or what we call extrapyramidal side effects, clozapine actually has the lowest risk of causing the actual movement problems.
Thank you so much. Next question says, how can one access ACT programs?
Oh, very good question. And harkening back to that race study, to add a point there, part of that study and why one of the reasons it came out was trying to focus on early psychosis intervention. They even came up with a set of programs, EpiNet, Early Psychosis Intervention Network. It was supposed to be this idea: you've got these national early psychosis intervention clinics throughout the country. They somewhat accomplished that. I will say every state does some differently, and using Chicago as an example, the closest EpiNet clinic is in Indiana. Again, with the third biggest city in the country, with the third biggest metropolitan area in the country, we don't have an EpiNet clinic here. The way Illinois does things is they divided the state into different regions. I believe Glenview, I believe this area is Region 2. I believe the city is Region 1. But the Department of DHS kind of contracts out to different organizations that are considered community mental health centers. I currently work at Advocate Lutheran General, for example. We're not a community mental health center from a dictionary definition standpoint. When you are a community mental health center, you have certain services, certain block grants, case managers, services you have to do, and other services that you might be doing. I used to moonlight, for example, at Advocate Masonic for 2 years, and they are a community mental health center. They do have an ACT team. And if somebody's homeless, for example, they are very difficult to find. They can't get transportation. I had cases where they would drive out to the Howard stop on Yale and actually pick someone up and get them a long-acting injectable medication. It's getting in contact with your local community health center. Typically, I refer people to NAMI for some of that referral information. Technically, you're supposed to be doing it through going to the Department of DHS for Illinois, finding what your local community health center is. But it's a very intricate system and, in my opinion, overly complicated. But the Illinois DHS, or honestly, I find the NAMI helpline helps navigate things better than the DHS website does.
Thank you, Dr. Filippo. Good question. Next question says, any relation between cannabis use and schizophrenia?
I think we'll both answer this if you feel comfortable, but Dr. Rooney, if you want to talk first, I'll talk second.
Certainly. So in short, yes. It's it can't certainly with the advent of legalized recreational cannabis in Illinois, certainly just in clinical experience, I've seen a lot of patients that have experienced a psychotic episode, after periods of significant cannabis use. And so, it certainly poses an etiologic dilemma when you're seeing a patient. Is the cannabis causing psychosis? Is someone predisposed for cannabis and as part of that stress diathesis model, does the cannabis use uh, kind of push someone over the tipping point to develop a psychotic episode? And at this point, we still really don't know. What we do know is that when someone is acutely intoxicated with cannabis, it's very common that people will experience kind of transient what we call micropsychotic experiences during the actual period of acute intoxication, things like paranoia, even sometimes things like auditory hallucinations. But certainly what we see more on the inpatient side is when someone uses cannabis, and usually it's after um, an extended period of use, is that we have these durable psychotic symptoms that persist even after the THC, the active chemical in cannabis leaves the body. So, in the DSM, we have basically two diagnoses that we work with. The first being what's called cannabis-induced psychotic disorder. That's kind of that is basically based on the onset of psychotic symptoms a short period of time after cannabis has been used, versus just a primary psychotic disorder, something like schizophrenia, and in addition to more chronic dependence on cannabis or a cannabis use disorder. And, again, these are descriptive diagnoses. We're still not really at the point where we know, can cannabis itself cause a psychotic disorder? At this point, I would say, really it comes back to someone's holistic risk for developing a psychotic illness. And certainly cannabis is one of those things that can precipitate a psychotic episode in someone that has risk. Um, eh, but at the same time, a lot of people use cannabis and don't experience these psychotic episodes. So, you know, at, can we at this time can we predict who's going to develop this very serious adverse reaction to cannabis? And at this point we really have no way of knowing. Looking at functional neuroimaging studies, um, there's some evidence that cannabis itself causes changes in this mesolimbic tract, in the mesocortical tract, that's actually distinct from other substances that we know can precipitate psychotic episodes. So we're still not 100% sure how cannabis kind of produces these psychotic syndromes, um, to what extent it contributes to psychotic illness, or if someone experiences a cannabis-induced psychotic disorder, what's their risk of experiencing a psychotic episode down the line, even if they abstain from cannabis. We're still at the point we really don't know. But certainly my recommendation to anyone that's experienced any sort of psychotic illness, whether it be schizophrenia, schizoaffective disorder, bipolar disorder, certainly I recommend to avoid any sort of cannabinoids, because we know it certainly does pose a risk for precipitating a psychotic episode.
Yeah, very well said. This gets to the age-old question of correlation versus causation. Yes, we know THC, especially high dosages of it, can cause symptoms of psychosis. These tend to be time limited, but it definitely can cause psychosis. Now, I don't think there's ever going to be a study that gives people high doses of THC, tracks the ones that become psychotic, give them to a multiple times later throughout life, and 6 years later, what's, do they meet criteria for schizophrenia? But not kind of the framework we have. I will say, to that point, from a genetic risk in the stress diathesis model, we know, for example, there's a small percentage of individuals that have a certain mutation in something called the COMT gene, catecholamine methyltransferase, kind of breaks down dopamine. We know individuals with this mutation that then take high doses of cannabis much more likely to develop psychosis and much more likely to later be diagnosed with schizophrenia. Correlation, causation, I can't honestly tell you based on that data, but somebody with a mutation versus not with a mutation, they get the same treatment, they have different outcomes. To me, I'm willing to hang my hat on that. Now, to put things in perspective as well, we know that many other things cause psychosis. Prior to legalization of marijuana in Illinois, I saw much more synthetic THC related psychosis than I saw natural THC related psychosis. Now that it's become legal, I see much less synthetic THC psychosis, or I guess a lot of the stuff you get in the store is synthetic, but I see much more from a prevalence standpoint. If you've got 100 people smoking legal marijuana versus one person smoking synthetic Delta THC 8 that you get at the gas station, you're likely going to have more psychosis from the legal stuff than the non. So I do think it's important to put that in perspective. There is a small amount of individuals who I would say are just unlucky, natural genetics, whatever you want to call it. They're going to develop schizophrenia symptoms and what I would call actual schizophrenia from overuse. The nice thing about this is in every case of treated, typically, they get treated on medications. Typically, they do well for a couple months. They relapse on marijuana. They may become psychotic again. We get them on medications again, and then they tend to learn, then I don't want to be on this. I'm unlucky. My body just reacts this way. So I do think there's a lot of hope and education there. I think it's important not to dance around the topic. Yes, marijuana can cause psychosis. Yes, there were a lot of bad things with the drug war, including the rise of synthetics and Delta 8 THC. I think it's important to be open about that. And if somebody is unlucky and falls in that category, they need to avoid it. And if they don't fall into that category, great. The other thing I'll say from a harm reduction standpoint is this is something we see from THC and correlated with higher dosing of THC. There are many other things in the marijuana plant, including CBD, cannabidiol. Cannabidiol also happens to be an FDA-approved seizure medication, Epidiolex. There's been 2 studies, I believe, that have actually shown cannabidiol might be somewhat protective from a psychosis standpoint. From a harm reduction standpoint, if somebody is going to use, I recommend they minimize the THC, maximize the CBD. Don't take that to an extreme. CBD is not completely benign. It does have some weird liver enzymes effects on certain antipsychotics, CYP3A4 metabolism. You don't need to remember that, but I have had cases where somebody is massively using CBD and it has led to medication side effects that could otherwise be prevented if we'd known about the amount of use. So small risk. I would definitely argue there's likely some causation there, but I can't honestly tell you there's causation, but we do know there's some very important genetic correlation.
Thank you so much. We do have a question. It has a little bit of a background story to it, so I will read this for you. It says, "Thank you for doing this lecture. My 32-year-old son has schizophrenia for the last 6 years. I give him a shot of Invega Sustenna, did I get that right? Every 3 weeks. He has a history of subdural hematoma at age 14 months and had heart surgery at 6 months of age. He always had a learning disability. However, now with the schizophrenia, his cognitive decline has gotten worse. He is now on Social Security disability. Have you seen this before? Thank you."
Definitely. Sadly, I think this is much more common than people think. And I will say to that point, people can develop schizophrenia later in life. The fact that there was the early insults to the brain, the subdural hematoma, and it sounds like an early learning disability, there very well may be what we call less of that cognitive reserve than somebody without those same insults to the brain. Example, when somebody is very well educated, a PhD, for example, and they're later diagnosed with dementia, there's this idea of something called cognitive reserve, the ability for cognition to decline before there is a functional impact. Somebody with more education, with a brain that has that cognitive reserve, there's more ability for that decline before it does have that functional impairment. In a case like this, where there's that early impairment from the hematoma, from what I suspect is a learning disability, possibly secondary to that, you add on the progressive decline in nature from schizophrenia, it can be very difficult to mitigate that. Now, I will say I'm very happy, and I think you bring up a very important point we didn't talk about this lecture with the Invega Sustenna. Invega Sustenna is a type of long-acting injectable antipsychotic. It's no better, it's no worse than an oral take once daily antipsychotic. One really nice thing about long-acting injectables is you don't have to take them every day, especially for somebody that's not overly adherent, especially when there is family to support that. You might be able to give them a once a month Invega Sustenna injection. Invega also has a version called Trinza, give once every 3 months. I'm not in charge of marketing or naming, but there's a newer version of Invega called Invega half year, that's given every 6 months. I think one of the most important things in mitigating damage, especially when there is not that great cognitive reserve, is making sure somebody is very adherent with treatment. Long-acting injectables, you know if somebody got it, you know if they're coming in once monthly or once every 3 weeks or once every 3 months or once every 6 months. That is, I think, key in preventing the decline. Sadly, we have very limited tools for helping the negative symptoms of schizophrenia. Sadly, just from a learning disorder enhancing cognition standpoint, we don't have a ton of tools out there. It can be difficult to kind of build up that cognition from where it is, but we definitely can help prevent the decline with the tools we have today.
Thank you so much. This was an extension to that question as well. So same situation, says, what do you think the long-term prognosis will be? He is living independently with much help from me. He is too afraid to come out of his apartment. What do you think may happen in the next 10 to 20 years?
And with that, I'll address what helps most with negative symptoms question above it, the loss of all desire. Currently, we have very limited treatments out there for negative symptoms of schizophrenia. I think this really highlights the importance of non-medication treatments out there, the importance of social skills training, the importance of cognitive remediation, the importance of supportive employment. If this is somebody with depression, it'd be very common. I use the type of therapy called behavioral activation. Example, somebody wants to go to the gym, train to run a marathon. I cannot run a marathon right now. If I tried, I would feel miserable. I'd fall down. I would be painful. I would feel discouraged. If instead you can break that into very small, achievable goals. Day 1, I'm going to drive to the gym. Day 2, I'll drive to the gym. I'll park in the parking lot and swipe my key card. Day 3, I drive to the gym, swipe my key card, walk over to the treadmill, but don't get on it. Day 4, drive to the gym, key card, treadmill, go on there for 5 minutes. Every day you accomplish the goal, you feel more motivated rather than demotivated. You make these very small, achievable goals to kind of build up to whatever the final goal is going to be. Now, that can seem daunting at first. I've never run a marathon. I doubt I'm ever going to run a marathon. But again, if you have a goal in mind, it might be as simple, relativistically speaking, as leaving the house. Oh, I'm going to go to the front step. I'm going to go open the door. I'm going to go, pick the mail from outside. I'm going to order an Amazon package and, open the door and kind of bring that in. But building up these small achievable goals, using that behavioral activation to get somebody there. I also think this is, again, highlights the importance of working with a therapist, working with an individual who can help this. If the family member you're able to, great. But these are not skills that the family member is necessarily trained in. You can get a lot of insight from a therapist who is doing this much of the day. I will make one plug out there. And again, I don't typically recommend things when they're research, but there is a medication under study currently. The brand name is eventually going to be CAR-XT, KAR-XT. It's interesting in that it was initially studied for Alzheimer's related psychosis, dementia. It was found to have like an improvement from a schizophrenia standpoint, or that was the theory. And they have come out with their first phase 3 trial. Just for reference, in order to get approved as a medication in this country, you need phase 1 trials, phase 2 trials, and then finally 2 phase 3 trials. The first phase 3 already came out and was successful, showed that there was great improvement from a negative symptom standpoint. If there wasn't that phase 3 trial, I wouldn't be recommending this as an option yet at this point. I will say they are doing clinical trials in Chicago right now. I believe they're out of Rush, and I believe their clinical trial facility, they've got one in Skokie. I don't know the website offhand, but if you Google CAR-XT clinical trial Chicago Rush, something's going to come up. I know they were enrolling as of a couple months ago. from a medication standpoint, that might be something worth looking into. That said, I think this really, these types of cases in particular and negative symptoms in particular, really highlight the importance of having that supported employment, that psychotherapy, that behavioral activation. I really think therapy is our best one tool we have today. I'm hopeful that we'll have more tools in the future.
Thank you, Dr. Filippo. Let's see, next question. I like this question. How does a person with a schizophrenia DX find a supportive work environment?
Dr. Rooney, do you want to answer that one?
Yeah, that's a good question. I think, the first thing to highlight is, schizophrenia itself is not a kind of uniform clinical presentation. It's a very heterogeneous kind of condition, and the specific suite of symptoms that someone can experience as part of the disorder really varies person to person. So certainly I think on an individual basis, kind of trying to identify as an individual what is one's most salient problem in living. Is it attention? Is it is it anxiety? Is it a degree of paranoia? Trying to kind of cater the work environment specifically to um what's the specific problem someone experiences, what the most important uh difficult aspect of the disease is for them. And in term and one thing I'd like to highlight is, schizophrenia. It's, certainly from my perspective, it's a medical illness, no different than something like diabetes, no different than something like chronic pain. I think it's important to kind of perceive it as such, but in like the eyes of the government in terms of FMLA, things like that, it's also recognized as a medical illness too. So all of the workplace rights and accommodations that someone would have for something like diabetes, certainly it applies to schizophrenia as well. So, certainly I when it comes to things such as um, uh, figuring out, the FMLA workplace accommodations, certainly there are systems in place to ensure that, someone, with the disorder can work and effectively navigate their work environment. And it's I think kind of from the perspective of, in the context that someone had a psychotic episode, perhaps their first psychotic episode, and they're evaluating, what's, you know, how much stress can I handle? What kind of a stressful work environment, can I manage? And it's truly on an individual basis. And what we know about medication intervention for schizophrenia is that when we have a therapeutic dose of the medication, the symptoms can be controlled so that today it can be something that is controlled consistently in remission, so people can do the things they want to do. So I certainly, if someone with schizophrenia is looking at starting a job, just starting any sort of new change in their life, any new objective, just because they have schizophrenia certainly doesn't mean that it limits what they can or can't do. But it's certainly contingent on where an individual is in the course of their life. If they're still in recovery after an acute psychotic episode, then certainly, I would exercise caution in seeking out things in life that could potentially cause a lot of stress. But if someone feels, solid, feels grounded in how they're doing, you know, the sky's the limit, truly.
Thank you so much. I appreciate that answer. Let's see, we have a couple more questions. Let's see, it is 8:34. So let's take maybe one more question. Are we good with that?
Maybe we'll do the next two, as I think the next one I think is more of a clarification from an earlier question. But I could definitely do the ketamine question as well. With the next one of Dr. Rooney, I think that was harkening back to the schizoaffective. I can take that, or you can take that, whatever you want.
Oh, sure. Yeah, I can. I've never used the Q&A tab here.
Did you just say bipolar psychosis is a psychotic disorder?
I see. Yeah. So, it's that answer would vary depending on who you talk to. In the DSM, bipolar with psychotic features is categorized within the subsection of bipolar disorder, and there's a specific subsection for schizophrenia spectrum and other psychotic disorders. So based on the DSM, they're distinct. I would say, again, it kind of harkens back to the fact that still in psychiatry, our diagnoses are descriptive. They don't specify what the actual cause of the illness is. And, as a corollary to that, I think it has important treatment implications, especially if, we have two diseases that are caused by similar pathophysiology. Certainly just because they're in different categories, it doesn't mean, one treatment that works for one wouldn't work for the other. So, in my perspective, bipolar disorder with psychotic features. So if someone has bipolar disorder and in the course of a manic episode or a major depressive episode secondary to bipolar disorder, they experience psychotic features. In my opinion, yes, I consider that to be a psychotic disorder because I'll basically kind of use three pieces of evidence to support that. The first is there was a large study, I believe was done at Hopkins, where they looked at people that had these different diagnoses, people that have been diagnosed, met the diagnostic criteria for schizoaffective disorder, bipolar disorder with psychotic features, and schizophrenia. And we look at, relative to the general population, what specific alleles of things like neurotransmitter receptors, neurotransmitter transporters, what specific kind of gene copies are more represented in populations of patients with these diagnoses as opposed to the general population. Thinking that, if these were distinct, pathophysiological processes, we would see three different groupings of kind of alleles that confer risk. And what was observed is that's not the case. Basically, we know that specific, genes that confer an increased risk for one of these disorders confers risk for all of them. Secondly, we know in looking at neuroimaging studies, the pattern of what's called cortical atrophy that accompanies things like schizophrenia is identical to what's seen in schizoaffective disorder, bipolar disorder with psychotic features. And finally, we know that the medications that are effective for one of these conditions is effective for all of them. So, from my perspective, I think of all of these conditions as falling under the umbrella category of psychotic illness, but certainly the specific presentation is it differs between each of these diagnoses, which is why we have the different diagnostic labels that we use, but from my perspective, all of these disorders, I feel reflect different sides of the same coin.
And adding on to that again, highlighting psychiatry, our definitions are based on descriptions. They're not necessarily based on what's happening in the individual's brain, but these diagnostic patterns, ideas, jargon, dictionary definitions would come up. So we can talk to somebody else and be like, this is bipolar disorder, this is schizoaffective disorder, this is schizophrenia. I think your question also does a great job of highlighting the difference between psychosis and schizophrenia. Schizophrenia, by definition, from a psychiatric perspective, you have to have those positive symptoms, there's negative symptoms, there's different symptom clusters out there. Psychosis itself doesn't necessarily have to be associated with that. Approximately half of bipolar disorder cases will eventually show some level of psychosis. Schizoaffective disorder is considered more the schizophrenia spectrum, as you have a lot more of those other neurological processes, a lot more of the negative symptoms, a lot more of the cognitive symptoms. And to be diagnosed as schizoaffective, you need to be having those symptoms separate from any type of mood episode. Now, with unipolar depression with psychotic features, you typically have psychotic components that are congruent with the depression. A voice telling you you're worthless, you're lazy, yada, yada. With bipolar, with psychotic features, you tend to have hallucinations that are more congruent with the mania. I think I'm the king of England. I think I'm a billionaire. If it's happy mania, it's saying good things about you. If it's not irritable mania, it might be saying very terrible things about you. The point being, for schizoaffective, it needs to be a distinct psychotic period from a distinct mood period. Bipolar psychotic features and unipolar depression with psychotic features, the mood has a psychosis with it. Again, these are imperfect labels, though, for a very complicated human organ. And I think we'll end with the next question on ketamine. Very interesting question. So I run our S-ketamine, Spravato clinic at Lutheran General Hospital. S-ketamine is the S isomer of ketamine. It's currently FDA approved for treatment-resistant depression and depression with acute suicidal ideation or behavior. It was interesting, but one of the major side effects and things we're looking out for with S-ketamine, which has a mandated 2-hour observation period, it's not something you can just do at home. One of the interesting side effects we're looking out for during that monitoring period is ketamine itself is a dissociative anesthetic. It makes people dissociate. There can be those feelings of, I'm not real, I don't exist, I'm not a person. When you get into the whole idea of psychedelics, there might be this idea from a therapy standpoint of ego death. Point being that there's a lot I can talk about with dissociation. That is a very separate component, very separate thing from psychosis. Initially, it was thought that you give somebody a dissociative anesthetic or you give somebody S-ketamine, it might worsen underlying psychosis. That has not panned out. I'm going to share my screen again, bringing up the circuit model. With this, it's interesting, but they've done studies with ketamine in individuals that have schizophrenia and those without schizophrenia. Ketamine for reference and S-ketamine for reference primarily work, or at least we think they work, as an NMDA antagonist, so kind of a blocker for this NMDA. And it's interesting, when you give people with schizophrenia, S-ketamine, ketamine, there has been a slight increase in the limbic system activation. There is a slight increase in the positive symptoms of what we call schizophrenia. There's actually no change, and there might be a slight improvement in the negative symptoms of schizophrenia. Coincidentally, certain other non-dissociative NMDA antagonists like memantine, Namenda are used in dementia, used for kind of enhancing cognition. Point being, it's not currently used for it. I would be a little worried about an acute exacerbation from some positive symptoms of schizophrenia in the short term. I will say it's not something I've seen clinically. I think there likely is benefit for individuals with schizoaffective disorder, depressive type, but it's currently only FDA approved for unipolar depression that's treatment resistant or with acute suicidal ideation or behavior. So it's not something we can get insurance to cover.
Thank you so much. I appreciate that answer. We do have 3 more. We could either stay or I could potentially send you these 3 questions. What are you feeling?
I can answer them real quickly, but might be a little bit less depth than the other ones. But from a tapering olanzapine standpoint, great question. It's very important to find the lowest effective minimum dose of the medication. Psychosis is a recurrent relapsing remitting disease, and part of the difficulty with any disease that can be in a flare-up is it can be very difficult to find out what that lowest effective tolerable dose is. If somebody is on Zyprexa olanzapine 20 milligrams, for example, the FDA approved maximum dose, you get them down to a microdose of 2.5 milligrams. They might not have another psychotic episode for 5 more years. Is that because the medicine was working, or they're on a placebo dose of it and it wasn't going to recur until 5 years anyway? I think this is really why it's so important to check in with your psychiatrist. And even if it is, you've been stable for years, especially with an underlying psychotic disorder, I never want somebody to go more than 3 months without seeing somebody. As you can monitor symptoms, you can catch them early. If they should be on 10 milligrams, but I got them down to 7.5 and I'm seeing them once a month or once every 3 months, you can typically get that treated well before it gets to the point of functional impairment, or more importantly, picking up the phone, calling your psychiatrist, letting them know you're experiencing these symptoms, or having your family members know this about you so they can be the ones to look out for that. As we talked a little bit about earlier, insight into this disease can be very difficult, especially in the beginning. It's very nice to have a canary in the coal mine, a family member, someone that's living with you that knows you well, that can see the warning signs maybe before you do. From a clozapine heart on the liver standpoint, yes, to a small degree, approximately 1 in 2,000 individuals on clozapine will develop a liver injury from it. The nice thing about this is it typically presents immediately or within the first few weeks of treatment. Yeah, again, you stop it and it goes away. It's not a permanent issue. I will say from a longer term perspective, the weight gain we see with clozapine can lead to fatty liver disease, which itself can lead to smaller elevations in liver enzymes. I can think of a handful of cases in my career where we've had to modify the dose based on it. I've never seen a case yet where it's led to significant enough liver injury we've taken somebody off clozaril. It's something to do the monitoring with, one of the reasons we do monitoring, but I wouldn't say it's a reason to dissuade somebody to stay away from that medication. From how many inpatient admissions at Lutheran General are via crisis intervention events? Good question. I wouldn't know the numbers completely offhand, but being a psychiatrist that takes call there, speaking from my own experience at least, I'll say approximately 60% of admissions to a unit are going to, 65% are going to be voluntary, 35% are going to be involuntarily. I will say of those, even of the voluntary ones, there are people who have the insight that want to come in but would otherwise meet criteria. I would put it at about a 50-50 where somebody would meet involuntary criteria. To that case, each state can be very different from what qualifies for inpatient admission criteria. Typically, the standard is going to be you're in immediate danger to self or others, or you're so disabled you're not able to take care of yourself. The specific verbiage varies a little bit state by state. California, for example, where I did medical school and college, you have the 5150 and the 72-hour hold based on danger to self, danger to others based on great disability. Illinois recently added a slightly, I think, better, or at least more liberal interpretation of what meets involuntary commitment criteria. I forget the exact verbiage, but it's if you don't have the insight to get treatment and you're going to soon get to the point where you're a danger to yourself or danger to others or gravely disabled, you can be admitted involuntarily based on that. One thing I will say, and I think important to differentiate also, is some states include substance use in this. Some states only include non-substance use mental health aspects. Illinois happens to be one of the states where substance use is not part of that. Point being, if somebody is very intoxicated, they're high on amphetamines or high in PCP, the presenting symptoms are thought to be from a substance use disorder. That's not something one can be admitted, or that's not one from reading the books or going purely by the books that one can be admitted for involuntarily. Wisconsin, for example, you very much are able to be admitted for that involuntarily. So one little quirk. If there is ever any question, I would say bring somebody to the emergency room for an evaluation. At the end of the day, we tend to take things, again, from a safety standpoint, you can admit somebody, they can be evaluated by a psychiatrist. I do have cases where I've admitted them overnight. I talk to them the next day, get a fuller, clearer picture, and discharge them that day. And there are plenty of cases where somebody's admitted overnight, involuntary. I talk to them the next day. They very much continue to meet involuntary criteria, but you can't know that until you've had the evaluation. And typically we are on the side of caution. And then that's the last one. Ketamine could be recommended for schizoaffective. It's not currently FDA approved for it. I see no reason it can't be or shouldn't be given or wouldn't have an effect in schizoaffective depressive type. I don't know any data for schizoaffective bipolar type, but it definitely has an antidepressant benefit. And given the monitored setting and the acute effects being gone within the 2 hours of monitoring, I'm not overly worried about psychosis. If it happens during those 2 hours, you're in a monitored setting, that's very much less risky than if it's happening on the outside and it's happening for weeks and weeks at a time.
Wow, you two are rock stars. Thank you so much. Thank you for staying a little bit later and answering our participants' questions. It is very meaningful, and we really do appreciate your time. And so for those of you who are still with us, if you did enjoy tonight's program, you can find more information about NAMI and more of our programs and events on our website at www.namiccns.org. Our next community webinar is going to be held on May 22nd from 7 o'clock to 8:30 p.m., where Megan Rosenzweig, a mental health professional from Joslin Center, will teach us what we need to know about personality disorder. Our May webinar is going to be sponsored that month by the Skokie Public Library. And lastly, NAMI CCNS's annual gala is going to be held on Saturday, May 11th. If you are interested in purchasing a ticket, please visit our website. It should be a really amazing event, and we hope to see you there. And once you log off, there is going to be a short survey. Please, please, please take it. It will be a 1 to 2 minute survey, very, very quick. It will not only let us know how we did and how we can improve for next time, but it also helps us raise money so we can write grants and continue to do these programs for free. So we really do appreciate your presence tonight, and we look forward to seeing you again at our next NAMI CCNS community webinar. Please take care of yourself and each other and have a wonderful night. And thank you so much, Dr. Filippo and Dr. Rooney. I hope you get a good night's sleep, and we will see you soon. Bye, everybody.